I bring warm greetings from India. I welcome the delegates who have logged in from all over the world and the faculty who are very enthusiastic to deliver the lectures. I am Dr. T.S. Chandrasekhar, your ACG Governor of India Region, American College of Gastroenterology. I bring warm greetings from the webinar subcommittee of American College of Gastroenterology and further greetings from the member scientific committee as a member, World Gastroenterology Organization, and from our institute also, Med India Hospital and Academy, and the university to which it is attached, the Dr. MGR Medical University. The first three webinar series saw the participation of over 19,000 delegates. Even during pandemic, COVID pandemic, we conducted the webinar and we saw the participation from all over the world. That created more enthusiasm for us to conduct the fourth series of webinar. And we gave the title, that tagline, name the topic, the world experts are here. And it created a news, yes, new Endo-GA webinar series from Med India Hospitals and Academy. And we scheduled 12 webinars from April 24 to March 25. Then again, we rescheduled it again, fourth series from the April 25 to March 26. This is the last of the fourth series webinar. It was inaugurated by Professor Dr. Jonathan Lighton, President of American College of Gastroenterology. And we saw the participation of the Nobel laureate. That was icing on the cake for our series of webinars. A Nobel Prize winner, Professor Dr. Barry Marshall, the discoverer of Helicobacter pylori, and which revolutionized the management of peptic ulcer and stomach cancer. And he delivered a talk on the journey of discovery of Helicobacter pylori and further. This webinars would not have been possible without the coordination and cooperation from my colleagues, Dr. Gokul, Satya, Raju Yogesh, Prasad, and Trinyana Sambandha. And now we see in these webinars now becoming more popular because, not only because of the coordination by my colleague, we saw the who is who in gastroenterology in India and international scenario also. Every board member of American College of Gastroenterology, every president of American College of Gastroenterology, they have participated in our webinar. That is the main reason, the popularity because of that. And the other faculty from India and rest of the world, they have moderated and they become the panelists for such our webinar and become a big success. This series we saw the topics, interesting topic, type 2 diabetes and GI tract, systemic hypertension and portal hypertension, current management of dyslipidemia and fat and liver, the storage to damage, pharmacotherapy of obesity, and endoscopic and surgical management of obesity. Then we saw some interesting topic like doctor and law, doctor and ethics, doctor and research grants, and further doctor and finance and doctor and entrepreneurship, and how to choose a research question, choosing the most appropriate study design, how to analyze the data and research methodology, manuscript writing and publication, masteral checkup in gastroenterology, precancerous lesion in gastroenterology, and we did have live demonstration of all the GI endoscopy procedure in February. Now we are in a big debate on endoscopy versus surgical management of in gray areas in gastroenterology. What is the physician to say and what is the surgeon's take on these areas? We know the surgery is the gold standard. There is no doubt about that. And the minimally invasive surgery is again the gold standard. Then why we need to have a debate on this? There are certain patients who are unfit for surgery, or there are minimally invasive endoscopy procedure can give equal results like surgery. So we need to define the boundaries where endoscopy will be beneficial, where the surgery is the final word. This is the reason we want to have a debate. And Tamil Nadu Medical Council has granted one credit hour for our webinar. And this topic has become very interesting. We saw the participation from all over the world. Debate endoscopy versus surgical management in gray areas in gastroenterology, physician and surgeon's perspective today. And we have eminent speakers from surgical side. And symbolically, I have chosen a very young endoscopist, meaning that the endoscopy is a relatively younger field compared to the surgery, which has been traditionally much older than the endoscopy. At the same time, we have two moderators, Professor David Haas and Professor Vivek Kaul. It's my pleasant duty to introduce the faculty now. The first speaker is Dr. T.C. Vivek Sandeep. He is graduated from Madras Medical College, India. He is now currently the Assistant Professor, Division of Gastroenterology and Hepatology, Augusta University, USA. He is the Director of Advanced Endoscopy and Associate Program Director for the GI Fellowship Program. And areas of interest include therapeutic endoscopy and quality improvement, outcomes reach, and artificial intelligence. He is the recipient of the Fellows winner in ACG North American Conference of Gastroenterology. I think that's a place where he met Professor Hans, and he has got several publications to his credit. And this will be moderated by Professor Dr. David Haas. He is the medical director for the Packed Gastroenterology Center, Connecticut, UDS, the director of endoscopy at Yale New Haven Hospital, St. Raphael campus. He serves as a trustee on the ACG Board of Trustees and served as faculty for the ACG virtual grant rounds in 2024. His areas of interest: inflammatory bowel disease and small bowel disorders and complementary therapies for GI disease. We welcome you both, Dr. Vivek Sandeep and Professor Hans. The second speaker is very popular and is very senior surgeon. He is the Director of Chief of Surgical Gastroenterology and Minimally Invasive Surgery, AEG Hospital, Hyderabad. Pioneer in natural orifice transluminal endoscopic surgery nodes. And to his credit, he has performed the world's first transoral endoscopic appendectomy in 2003. He recently has been honored by the government of India with a prestigious Padma Shri Award, and earlier he has received B.C. Roy Award in 2000. Professor Vivek Kaul, again another eminent physician, gastroenterologist, Segal Watson, Professor of Medicine and former Chief of Gastroenterology and Hepatology, University of Rochester Medical Center in Rochester, New York Board of Trustees and ACG USA, and is the President-elect, and we have the President-elect of World Gastroenterology Organization in our faculty. He chairs the ACG Innovation and Technology Committee and the ACG US Special Interest Group and the World Gastroenterology Organization Endoscopy Committee. He has been the principal investigator on national and international clinical trials. He does have several publications to his credit. And we have eminent people in the panel who would discuss after both the lectures. Dr. M.S. Prasad, Senior Consultant Surgeon, Med India Hospital, Chennai, and equally very prominent and eminent surgical gastroenterologist, Dr. Beju Senadipan, who is a Senior Consultant Surgeon, SK Hospital, Trivandrum. We have a panelist from Sri Lanka, Professor Dr. Bhavanta Gamay, and he's a Professor of Surgery, Department of Surgery from Sri Lanka. And I welcome you all, the faculty and the delegates, once again. And I was wondering how Dr. Professor Harz was asking, how come this webinar has become so popular? Because this is because of our national ambassadors from various parts of the India, from Dr. Chaubal, Dr. Praveen Roy, Ramesh, Srinivas, Praveen Kumar, Arvind Gubbi, Greece, and so many people represented each state of our country. And Usually, we have international ambassadors from USA, Malaysia, Nepal, Bangladesh, Nigeria, etc. So with this, it's my duty to hand over, it's a pleasant job to hand over the mic to Professor David Hayes to start the proceedings, to conduct the proceedings of the first lecture. Thank you very much.
Well, thank you very much, Dr. Chandrasekhar. It's a true privilege to be here, and I'm really looking forward to learning with everyone and from everyone today. I think we have two really wonderful lectures. We're going to start with Dr. Vivek Sandeep talking about endoscopy versus surgical management in the gray areas of gastroenterology, the physician's perspective and the GI perspective. And I think we're going to hear how there's a lot of overlap now, and there's a lot of exciting innovation going on in the endoscopic world. And I'm hopeful that by the end of these lectures, we can find ways that we can enhance each other's abilities in doing what's right for patients and performing quality care and pushing the needle even further to take care of our patients in the best way possible. So for that, I'll turn it over to Dr. Vivek Sandeep to give his lecture, and then we'll have a lecture after that, and then we'll have a moderating panel.
All right, thank you so much, Dr. Haas, for your kind words. I'm going to share my slides now. Is everyone able to see my slides?
Yes.
Perfect. So at the outset, I would first like to thank Dr. Chandrasekhar and the organizing team of MedIndia Hospitals for having me here. They've been doing a great job with these webinars every month, and I'm glad I had the opportunity today. I have no financial disclosures for my talk. And it's a very interesting topic given gray areas in gastroenterology. So how do we define gray areas? In my mind, gray area is the area where there's actually good data supporting the role for both GI and surgery, and we're not sure who has the major hand. Or if there's no clear consensus regarding who has a better role, when there's lack of high quality data, we don't know what is the real role. If a condition has been historically managed surgically, but there are upcoming GI techniques which are minimally invasive and have shown excellent results, they're good or even better. And also, spectrum of a particular disease or disorder where there is actually a role for both GI and surgery, for example, like necrotizing pancreatitis. So we have gray areas in every field. Within the field of gastroenterology, there are gray areas in terms of how we manage patients. There's gray areas when it comes to GI versus interventional radiology. For example, EUS-guided gallbladder drainage versus biliary drainage compared with interventional radiology, portal pressure measurements, etc. But since this is a debate and my opponent is a surgeon, I'm in the interest of that, I'm going to restrict my topics only to GI versus surgery, specifically endoscopy versus surgery. And the very first topic that came to my mind when I got this topic was achalasia. And the comparison is between POEM and laparoscopic Heller's myotomy. And as you know, Heller's myotomy is the gold standard. There is no question about that. We have decades of strong data, but in the last 10, 15 years since, Professor Inoue came up with this technique, POEM, this is the modern alternative and the challenger. And in fact, we have two major randomized control trials comparing these two techniques. And one of them actually published a new study last year with 5-year follow-up data. We obviously have more multiple cohort studies and meta-analyses also on this topic. So when it comes to efficacy, 1-year and 2-year success published by both these trials, one from Brazil and the other one from Europe, the efficacy is comparable between both these groups. And in fact, when they followed up these patients over 5 years from the New England Journal study, which was published in Lancet last year, the results were again comparable in terms of efficacy. Looking at the quality of life, POEM actually had a significant benefit when it improved quality of life across 8 different domains, versus Heller's myotomy improved only 3 domains. From a procedural efficiency standpoint, POEM is more minimally invasive, so obviously less procedure time, less exposure to anesthesia, but from a length of stay perspective, at least from randomized control trials, they're similar. Safety profile and adverse events. In randomized controlled trials, they're comparable. Major adverse events are similar. cohort studies also show similar data, and meta-analysis again supports it. So overall, it's a balance between both these techniques. The biggest pushback when it comes to POEM, though, is the GERD phenomenon, the reflux phenomenon. And in this 5-year data from the randomized control trial, you can actually see that there's a big difference in esophagitis. But luckily, most of these esophagitis are mild grade, LA grade A or B. And when they followed these patients over 5 years, you could actually see the gap narrowing between both these techniques. When they actually did acid exposure study, unfortunately, POEM patients definitely had more acid exposure, and there's a component of silent GERD that can happen in these patients. And when you look at the PPI use over 5 years, patients who had POEM definitely had a higher rate of use. Recently, we have this new upcoming technique called POEM-F, or POEM with endoscopic fundoplication, again described first by Professor Inoue, and we have a lot of data on this topic that's upcoming. In fact, most recently, we had a study published from India by Professor Bapai, and he published 3-year follow-up for these patients with nearly 35 patients in each arm. And you can see that it actually reduces the GERD by 4 to 5 times compared to just regular POEM, not compromising on the integrity of the fundoplication. And when it comes to guidelines for type 1 and type 2 achalasia, both the GI and the surgical guidelines say that POEM and Hiller's myotomy are highly effective. But when it comes to type 3 achalasia, actually POEM is the preferred treatment option because you're able to tailor a longer myotomy, and even the surgical guideline acknowledges it. So my clinical verdict is efficacy and safety. They're both similar. From a procedural metrics perspective, POEM is definitely superior. The only pushback is GERD, but most of them seem to be milder, but we have new upcoming techniques to help with that also. So algorithm in the future would probably look something like this, where when someone gets diagnosed with achalasia with type 3, POEM is the first line treatment option. And if it's type 1 or 2, you have both these, which are equally good. And then we have to make a shared decision making with the patients, whether they're averse to surgery, averse to taking medications, which will help us guide how we can manage these patients. And in the future, we certainly need more studies to look at long-term surveillance, especially with the silent reflux phenomenon, to look for Barrett's esophagus, and the role of hybrid solutions like POEM with fundoplication, and compare that with laparoscopic Hiller's myotomy. The next topic, again, that came to my mind is malignant gastric outlet obstruction. And again, the historical gold standard has always been surgical gastrojejunostomy, but we have a challenge now with endoscopic ultrasound-guided gastrojejunostomy. And unfortunately, these patients have a double hit phenomenon with starvation leading to malnutrition and treatment suspension. So they already have a low quality of life, and they tend to have a higher mortality. We used to do duodenal stents. That used to be our best option. Unfortunately, it was not as good or durable as surgical gastrojejunostomy. But with the advent of lumen opposing metal stent, we have a more minimally invasive EUS-guided approach. And on this particular topic, we have 2 randomized controlled trials, the Enduro trial and the other trial from Orlando Group. And there's multiple cohort studies and meta-analysis on this topic. And when we look at the randomized controlled data, the efficacy in terms of technical and clinical success, they're comparable in both these groups. But the biggest difference is median time to oral intake. So why do we do this procedure? What it means for the patient? This is probably the most important outcome, I would say. And definitely it was in favor of EUS-guided gastrojejunostomy. And in fact, the randomized controlled trial data from Orlando showed that 100% of the patients were discharged with solid diet, while it was lower in the surgical group. And also, as with most endoscopic techniques, the median length of hospital stay is also lower in endoscopic group. The other important outcome from an oncological standpoint is how soon can these patients get chemotherapy? And clearly, the endoscopic ultrasound guided gastrojejunostomy group had a 2 to 3 week advantage over the surgical cohort. In terms of adverse events, most large cohorts and even randomized control trials have shown that overall adverse events are lower with the EUS group. Of course, surgical GJ is a surgery. You have incisions, you have infections related to that, wound dehiscence, etc. The main risk with endoscopic gastrojejunostomy seems to be stent related. Another point to actually focus on is these are very frail and sick patients. They'll have low albumin, they're very malnourished. So surgeons frequently have to delay a gastrojejunostomy to nutritionally optimize these patients, while we certainly have a big advantage in trying to do an endoscopic approach for these patients. We're able to do them a lot quicker. In terms of recurrent gastric outlet obstruction and reinterventions, most big cohorts and even one of the RCTs showed that the reintervention rates were actually lower with the endoscopic approach. And if there is any stent blockage, it's a simple endoscopy where you're able to relieve the blockage even if there's a reintervention needed. And other big cohort studies actually have shown similar results. From a quality of life perspective, obviously you're not undergoing a major surgery. An endoscopic approach seems to have a higher quality of life. And in terms of cost, both are one-time procedures for the most part, and the cost seems to be in favor of endoscopic ultrasound. So what do the guidelines say? The European guideline gives a strong recommendation for considering EUS gastrojejunostomy in these patients, and the American Gastroenterology-Physicians says it's an acceptable alternative. If you look at the surgical literature, there's not much guidance. It's still surgical gastrojejunostomy is still the gold standard, but I think we may be seeing a shift in the future. So when we compare these techniques, obviously the durability seems similar, technical clinical success seems similar, but endoscopic ultrasound-guided approach has an advantage over recovery and chemoreception. So it's come a full circle. It really covers all the bases from a durability perspective, recovery, and oncology perspective. So in my mind, if it's a patient with gastric outlet obstruction in an expert center, EUS gastroenterostomy should be considered as a first line. The next topic is weighing the scales. So we're comparing two different techniques in the field of endobariatrics and bariatric surgery. So endoscopic sleeve gastroplasty and laparoscopic sleeve gastrectomy. Unfortunately, we don't have any RCTs on this topic. There's actually one underway, which is called the Tesla-Nash trials, but we have a lot of cohort studies that are matched. And these are two different techniques. With sleeve gastrectomy, you're basically amputating most of the stomach, versus in ESG, the anatomy is intact. It's just a full thickness plication that we're doing. When we look at the weight loss outcomes in most studies, there's no question that you could achieve more weight loss at whatever time frame with the laparoscopic sleeve gastrectomy. The largest study on this topic, where they had more than 3,000 propensity matched pairs, showed that the rates were comparable or non-inferior. But if you actually look at the numerical outcomes, the numbers were definitely higher with the laparoscopic sleeve gastrectomy. So there's no question about that. In terms of comorbidities remission, diabetes, hypertension, hyperlipidemia, most of these studies show that they're both equivalent in terms of improving comorbidities. And adverse events rates, of course, with most minimally invasive techniques, endoscopy seems to have the edge. Most of the study report less adverse events, and they're mild and managed conservatively, versus with laparoscopic sleeve gastrectomy, you may have to worry about staple leaks, hemorrhage, readmission, etc. From a length of stay and procedural metrics perspective, ESG definitely has the upper hand. Quality of life seems to be better with the endoscopic group, but the biggest difference, I would say, is we are seeing in the incidence of new onset or de novo GERD and Barrett's esophagus. Clearly, most of these cohort studies show that laparoscopic sleeve gastrectomy has significantly higher rates of GERD compared to ESG. So there is long-term success that's established with this technique. We're also able to do a repeat endoscopic sleeve gastroplasty if needed, or if it doesn't work, we're able to convert to a laparoscopic sleeve gastrectomy too. So certainly preserving the anatomy, the blood supply with ESG seems to have an advantage and preserve all future options. Another interesting finding to note is when they categorize patients based on BMI less than 40 versus more than 40, the difference was not significantly seen with BMI less than 40 group, but when it was more than 40, certainly surgery seems to hold the advantage. So when we compare these techniques, absolute weight loss, no question, surgery seems to have the upper hand. But when you look at all the other metrics in terms of comorbidity resolution, adverse events, GERD, quality of life, ESG certainly seems to have the upper hand. So in my mind, an ideal candidate for ESG is probably someone who has class 1 or class 2 obesity, who has a higher risk of GERD, who is averse to having a surgery, wants to have a better quality of life, versus if someone has class 3 obesity, clearly a sleeve gastrectomy may be a better option, but we need to make sure they don't have severe esophagitis or GERD. One thing I wanted to mention before we move on to the next topic is how anti-obesity medications is going to revolutionize this field. We're looking at a lot of studies coming out in comparison or in combination with ESG and LSG, and these are able to achieve synergistic weight loss. In fact, when they combined liraglutide with ESG, they showed that the weight loss achieved is comparable with the laparoscopic sleeve gastrectomy. From a cost perspective, ESG certainly has a significant advantage. It's a one-time procedure for the most part, but these medications are expensive, and being lifelong on these medications is not practical. So we're looking at studies coming out with combination therapies, and when do we give this medication, before or after sleeve gastroplasty? So a lot of data is yet to come out, but we have promising data already. So in my mind, in future, why is this a gray area? Because even though we have a weight loss ladder in terms of lifestyle modifications, pharmacotherapy, ESG certainly has found a role between these two, but the addition of these medications with ESG is significantly going to change the landscape and probably going to flip a lot of these patients towards endoscopy in the future. Next topic is altered anatomy, mainly ruined by gastric bypass, and we're going to compare an endoscopic technique, which is EDGE, and the traditional gold standard, which is a laparoscopic assisted ERCP. Unfortunately, we don't have RCTs, but we have cohort studies and meta-analysis available. So endoscopically, the main option that used to be in the past was enteroscopy assisted ERCP, either a single or double balloon. The drawback with this procedure is, it's not always successful. Even if you reach the ampulla, it's a smaller channel, so the instruments that you use are very limited. So it's a very challenging procedure. So laparoscopy assisted ERCP was always the gold standard. But as always, as I mentioned earlier, with the introduction of LAMS, or lumen opposing metal stents, EDGE has certainly revolutionized this field. So we basically create a bypass with the remnant stomach, and through that, we're able to do a ERCP successfully. When we look at the outcomes in terms of technical and clinical success, again, this is not randomized controlled data, but most of the cohort studies show similar success in both these techniques, and significantly better with just in comparison to just an enteroscopy assisted ERCP. Procedure metrics, again, the duration is shorter. There's no surgical preparation, no incision, no port placement, no need to go to the OR. We're able to do in the endoscopy suite. And we're also able to do as a single session EDGE sometimes. In terms of length of stay, definitely in favor of the endoscopy technique. Most of these actually get it as an outpatient and get discharged the same day. Cost benefit also seems to be favor in terms of in comparison with the laparoscopy technique, more in favor of EDGE. Adverse events, they are similar in both the groups. Both of these eventually involve a ERCP, so those risks are similar. But when it comes to laparoscopy, there's always a small risk of conversion to an open laparotomy because of adhesions or complications. And obviously, there are surgical complications, like I mentioned earlier, with wound dehiscence, hernias, etc. With the EDGE technique, the main complication that we need to worry about is stent migration or dislodgement, but that seems to be getting better with suturing techniques and having the stent in place. I did mention that we're able to do this even as a single session EDGE, where we do the EUS portion and the ERCP portion same sitting. Of course, there's a high risk of stent migration. It's not done by everyone. It should be done only by experts. But the traditional way of doing this is a 2-session where we do the EUS portion first, and 2 to 3 weeks later, we do the ERCP. The main concern with the EDGE technique that's been brought up is the fistula. What happens to the fistula once you remove the stent? And surprisingly, or thankfully, I would say, most of these have closed spontaneously, about 50% of them. And the other 50% were able to manage with endoscopic suturing or clip placement or just APC. But what's the clinical impact of this? Even though the studies say that there's about 10 to 30% of patients with persistent fistula, how does it translate to weight impact? Most patients actually don't gain a significant amount of weight. In fact, 60% of them gain less than 5 pounds. It's rare that people gain more than 10, 15 pounds. And that's basically because this is a temporary fistula and most of them close on their own. So in comparison, even though the technical and clinical success is similar in both these techniques, from a procedural perspective, hospital stay, cost profile, and the fact that just one person, an endoscopist, can do this technique definitely seems to favor edge. What do our guidelines say? The American Society seems to be favoring edge over laparoscopy-assisted technique. The European guidelines says edge is acceptable. The surgical guidelines still consider laparoscopic ERCP as the gold standard. Eventually, I think in the future, we'll be seeing a shift. But in my mind, it's not just about the ability to do a procedure or competency which dictates how we manage these patients, right? We have to look at why we're doing the ERCP in the first place. Is it just a one-time ERCP for removal of a small stone? Or does the patient have an ampullary mass or a stricture in the bile duct that needs multiple ERCPs with stents? Or if you have a complication from an ERCP like a post-sphincterotomy bleed and you need repeat access to go back, I think in all these scenarios, having an access with internal access through edge is a much better option. Moving on to the next topic is anti-reflux therapies for refractory GERD. And again, the gold standard is fundoplication or Nissen fundoplication. And the challenger or the new endoscopic technique we have is called the TIF, transoral incisionless fundoplication. Unfortunately, no RCTs yet, but we have a lot of cohort studies. And we have to understand how we offer treatment for GERD for our patients. Even though the fundoplication is the gold standard, not everyone can get it, not everyone wants it, and PPI is not good enough to control symptoms in half of our patients. So we need something in between as a gap filler, and that's where I think TIF and CTIF comes in and plays a big role. So we started off with surgeries with the Nissen 360 wrap, and then we have the Dor and Toupet partial wraps, 270. But TIF, the bottom left picture you can see is something we can do completely endoscopically in patients who have less than 2 centimeter hiatal hernia. But if someone has a bigger hiatal hernia, more than 2 centimeter, we certainly need a hybrid approach called the concomitant TIF, where a hiatal hernia repair is performed by a surgeon and then an endoscopic TIF. And when we look at the outcomes, so symptom control, PPI discontinuation rates, most of these studies show that the rates are similar. In terms of decreasing the GERD quality life score, it actually is similar. And we actually have good long-term data with TIF. In fact, we have series which report 8-year, 9-year, 10-year data, and nearly 70 to 80% of patients who have TIF maintain a successful outcome. But in my mind, or in anyone's mind, there should be no question the gold standard is still the Nissen fundoplication in terms of achieving maximum acid control. The 360 wrap or the Nissen fundoplication works the best. But the differentiator is why do we need something else if something is already good? Is the dysphagia and gas bloat syndrome or the post-fundoplication syndrome. The rates are obviously higher in Nissen fundoplication compared to TIF or CTIF. In terms of adverse events, similar to most endoscopy techniques, it's lower with the TIF compared to Nissen or even a partial fundoplication. Early discharge is possible. A lot of these patients can be discharged on the same day, but traditionally we admit them at least for overnight for monitoring. But when you compare the studies, most of them get discharged earlier compared to their surgical counterparts. And that's evident in most of these studies. And the readmission rates also seem to be lower in the first 30 days with the TIF technique. Guidelines, I know it's a lot of words, but all these guidelines basically say we can consider TIF. There's no strong recommendation to do TIF at this point. We can consider TIF as a standalone technique in patients who have less than 2 centimeter hiatal hernia. But I think in the future, when we get more studies, especially randomized controlled trial data, we may be able to see a better stratification. But in my mind, this is how I view this topic and how I think the future might be. If someone has a hiatal hernia less than 2 centimeter, but has a high fear of bloating or post-fundoplication dysphagia, they would be a great candidate for just an endoscopic TIF. But if there's a bigger hernia, then C-TIF is probably a good option for them. But if someone prioritizes absolute acid control or has Barrett's esophagus or severe esophagitis, they should actually be offered a surgical fundoplication from the beginning. All right, moving on to the last topic now is chronic pancreatitis, and we're going to compare endoscopy versus surgery. And the clinical dilemma, unfortunately, in a lot of these patients is, they're in pain, a lot of them in intractable pain. And we have two approaches, which is the traditional step-up approach and the early surgery approach. The endoscopy step-up approach, even though it's the most widely practiced, there are some drawbacks. A lot of these patients have repeated need for procedures. They're on medical management with pain medications, especially opioids. And once we exhaust our endoscopic options, eventually we send them to, as a last resort, for salvage surgery. There is actually randomized controlled trial data on this topic spanning a couple of decades. The first one was published in the New England Journal, and they had a long-term follow-up for 5 years for that. And then the most recent one is the ESCAPE trial published in JAMA, and they actually have an 8-year follow-up for these patients. And of course, a lot of studies get published from the Dutch Pancreatitis Study Group on this topic. And actually looking at the outcomes, complete pain relief and patient satisfaction, long-term data clearly in favor of surgery. And if you look at the median number of procedures required, unfortunately, with the endoscopy step-up approach, there is a need for multiple procedures compared to surgery. And the adverse events, when you look at just one event, endoscopy versus surgery, surgery tends to have significantly higher morbidity and adverse events. But cumulatively, when you look at all these endoscopies put together, it kind of evens out. So adverse events are balanced eventually in both these techniques. The unfortunate part is more than or nearly half of these patients cross over from endoscopy maintenance to need for surgery, which is salvage surgery. And in terms of costs, yes, surgery is definitely more expensive upfront, but endoscopy, when you add the number of procedures over time, eventually the cost adds up and equals out. A very interesting thing to notice is how do these patients do when they go for early upfront surgery versus, they fail endoscopy and eventually they go for salvage surgery. There's clear evidence showing that the pain relief is significantly better in a patient who has an upfront surgery versus a salvage surgery. Now let's look at our guidelines. The European Society clearly says endoscopy first approach. The American College of Gastroenterology says if endoscopy is exhausted, then send for surgery. But the other surgical guidelines and international consensus statement and in the American Society of Gastrointestinal Endoscopy says actually consider surgical evaluation first, even before committing to endoscopic management. So if you look at the guidelines, they're kind of all over the place and they're very divided in their opinion. So if surgical outcomes are so good, why is clinical practice so different? I mean, you would definitely agree that most patients actually end up along the endoscopy pathway. And the reasons I could think of were, all these RCTs, they had a selection of narrow phenotype of patients, dilated ducts, 6 millimeter or more, no multifocal strictures, no inflammatory masses in the pancreas. That's not always what we see in clinical practice. We do see multifocal strictures and narrow ducts. Despite the studies, many patients still respond well to endoscopy, and they may have a concomitant biliary stricture because a benign stricture from chronic pancreatitis, then you certainly need a ERCP. There's always a fear associated with the morbidity and patient preference when it comes to surgery. And the biggest point, in my opinion, is the expertise and access to pancreatic surgeons. Not everyone wants to deal with these patients. We don't have the expertise available everywhere compared to ERCP, which is much more prevalent and common. So that's why in reality, in clinical practice, I feel like there's a big disconnect between what the RCTs show and what we actually do. So when is endoscopy the right choice? Patients with strict contraindications or poor surgical candidates or multiple comorbidities. patient preference, obviously, for a less invasive approach. And when there's a favorable anatomy, if you have uncomplicated stones, or if there's a larger stone, if they're amenable to lithotripsy or ESWL, and complete duct clearance can be achieved, I think these are reasonable endoscopic candidates. So other topics that I could think of and I wanted to touch upon, but given that we don't have time, I did not go into details. Peripancreatic wall duct necrosis is a favorite topic of mine. In fact, I gave a talk on this topic a few years ago. Endoscopy versus surgical management. I think in the last 15 years, since that first study got published by the Dutch pancreatitis group, the PANTHER trial, there's been the tension and extension trial, penguin trial, MISA trial. It's clearly in favor of endoscopy in a lot of these patients, minimally invasive approach. But we do see a lot of patients where there's heavy necrosum, where we're struggling with endoscopy despite whatever we do. There's nothing we can do beyond a certain point. And that's when I think surgery has a clearly important role. Common bile duct stones, surprisingly, the literature is similar to chronic pancreatitis. You see the data in RCTs, the laparoscopic common bile duct exploration is better. It's a one-step procedure, can be done by an expert surgeon, but that's not what we see in reality in clinical practice. And I think we can discuss about it during panel discussion later. Traditionally, we do the ERCP followed by cholecystectomy approach in clinical practice. Ileocolonic Crohn's disease, specifically terminal ileal disease, early surgery versus medical management. That's the LYRIC trial actually showed that early surgery is very good, but that's not always what we see in clinical practice. So that's a gray area too. And of course, early cancers, esophagus, gastric, or colon, endoscopic submucosal dissection versus surgical resection. That's a huge topic of debate. Are we just achieving anatomic resection, or are we achieving oncologic clearance? That's the big question and the gray area. So these are some topics that are also considered gray areas in my opinion. So eventually, how do we resolve these gray areas? I think it's very important to establish an outcome hierarchy. When we deal with a particular condition or patient, we need to know what is the most important outcome we need to achieve. Risk stratification of patients. Are these patients even surgical candidates? Are they high risk? I think that can swing towards endoscopy in a lot of patients. Shared decision making is probably going to be the future and the most important thing. What does the patient actually want from a particular procedure? So that will be very helpful. Of course, cost effectiveness always has to be taken into account. The US healthcare system is so different from the Indian system. So decisions can be different in different areas based on the cost. Insurance obviously dictates and plays a big role in how we manage some of these patients. Access to care and experts, I think, is the biggest point in my opinion, because we see studies, we see great data from endoscopy or surgery, but if there is not a good endoscopist or a good surgeon who can do that, it doesn't mean much for the patient. So I think that plays a big role too. And eventually, in an ideal scenario, I think we need to have a multidisciplinary approach with the patient in mind, and the gastroenterologist and the surgeon debating what's the best approach for a particular patient. So I wanted to conclude with this slide. In the pursuit of excellence in providing great quality of care for our patients, I feel like even though surgery for a lot of these conditions is a traditional approach, it's not a static approach. It's a dynamic equilibrium. So the pendulum, I think, is slowly moving towards endoscopy in a lot of these conditions. And if we have this debate 5 years from now, I think the pendulum would have probably swung towards endoscopy a little more. So we're breaching the frontiers, we're expanding the horizons, and I think that's how our field improves and develops. So what we need to keep in mind at the end of the day is patients. So individualized patient care, patient-centric medicine is what we need to focus on and provide the best possible care for our patients. Again, I thank you very much for this opportunity, and I now look forward to Dr. G.V. Rao's talk. Thank you.
Dr. Viv, that was absolutely excellent. I learned so much, and I think it's going to be a wonderful panel discussion. You did an amazing job of highlighting the benefits of both different approaches, and that last slide is really important, that the pendulum is constantly swinging back and forth, and we have to figure out ways to be working together and collaboratively to deliver the best care. Is Vivek on, or should I introduce Dr. G.V. Rao?
Thank you, Vivek, for a nice talk, and Professor Has. We will take up the question after the second talk. Now I'll invite Professor Vivek Kaul or Dr. Prasad to introduce the topic and welcome Dr. G.V. Rao. Dr. Vivek Kaul?
Yes, hi, I'm here and I'm listening. Well, thank you, Dr. TSC, first of all, to invite me and, of course, the leadership of the American College for this joint collaborative endorsed seminar and webinar series. It is my great pleasure to be here once again. I've been here before, and I remember you putting me to the test with some very insightful questions in the panel discussion. So without further ado, an excellent talk, by the way, by Dr. Vivek Sandeep. And we look forward to the questions. But I think without further ado, we'll introduce my good friend and colleague, Dr. G.V. Rao. I think he will present the surgical side of the debate. I don't see him on the Zoom. Is he there, or am I just missing him?
Yes, come. Yes, come.
Okay,
he
good.
Is already
Okay, good. So Dr. G.V. Rao, as you said, is the director of the AIG hospital system and works closely with the chair, Dr. Nagi Reddy, and they've collectively developed the legendary system there and the healthcare setup. And of course, he's an excellent surgeon, and we have a lot to learn from what he has to tell us today. And I look forward to the debate after the second talk.
Thank you so much. At the outset, let me thank TSC for the honor of this screen. Thank Vivek and David for chairing the session and all the members who have logged in to see this. Congratulations, Vivek. Fantastic talk. Actually, you saved a lot of my trouble because I don't have to show all the data. I'll just show you some of the areas which I feel are the gray areas between surgery and endoscopy. Disclaimer, I'm also passionate about endoscopy, but I'm very obsessive about surgery. So some of the statements could be very radical. Please bear with me. Geographically, we have two types of zones, actually. We have these blue zones, where these are geographic areas of high longevity. I think I attribute this to surgery. In the sense, traditionally, people live longer because the interventions have been standardized. People live longer. Quality of life is better in these patients, and surgery can definitely be compared to the blue zones of the geographic areas. And we have gray zones, which are the areas of geopolitical conflict, as you see today, as in today. We call them the gray zones. And within the gray zones, there are several other gray zones, actually. Now you're talking about endoscopy versus surgery. And there is endoscopy versus endoscopy. And further conflicts, endoscopy 1 versus endoscopy 2 versus endoscopy 3. So we haven't had the final say from the endoscopic world as to which endoscopic procedure is superior to the conventionally practiced surgical procedure. I'll show you a couple of examples, and I'm sure that I'll be able to convince all of you that some of these procedures, because unless and until we have a standardized endoscopy procedure, we cannot compare it with the standardized surgical procedure as of today. The surgical strengths are that it's a gold standard. It defines the standard of care and cure. The principles and protocols have evolved historically from surgery. It's a definitive modality against which all therapeutic interventions are measured or scored. We have durable outcomes, the completeness of the procedure, there is oncological certainty, and there is teamwork involved in the entire procedure. In gastroenterology, as rightly said by the chairperson, care is all about patient. It is patient-centric, and interventions and decisions are based on evidence, basically relating to morbidity, mortality, quality of life, and economics. And endoscopic evidence is based on interventions. Now, there are variable practices, expertise, standards, and acceptance across the globe. publications and evidence that is produced is region-centric. The varying genophenotypes of patients involved in this. There are limited number of global multi-centric trials. Meta-analysis may be a global verdict or an answer to these things, as in today, but surgery is still the global gold standard for all the procedures. Procedures practiced in one part of the world may not be the standard of practice in the rest of the world. In gastrointestinal disease management, we have deal with the diagnosis, therapy, and follow-up of these patients. Actually, there is no two thoughts that as far as diagnosis and follow-up of patients is concerned, endoscopy rules over surgery. The entire credit goes to endoscopy. When it comes to therapy part, we have a lot of areas, gray zones or gray areas that we call, wherein we have to decide which type of therapy is better for the patient. As in today, we have 7 alternatives to evidence-based medicine. These are all the types of medicine that we take, and then we talk about the conventional randomized control or evidence-based medicine. Of late, actually, surgeons started talking about this confidence. You keep thumping your chest saying that this is the best procedure because only I can do this procedure. Now, this confidence or bravado, this thing has also seeped into the endoscopists right now, and we see a lot of these small population studies that are coming in to show that some of the procedures are technically feasible. Now, endoscopic evidence based on published evidence. Now, this entire evidence is published by 1% of the endoscopists who are innovators or researchers. This is propagated by 9% of the endoscopists whom we call as educators or early adapters. And 90% of the endoscopists practice this who are the practitioners. So it is literally 1% of the entire endoscopist population who is dictating what has to be practiced, and it could be different in different parts of the world. A couple of examples I'll show you where endoscopy is considered equivalent to surgery. Achalasia cardia, CBD stones, early GI cancers, old of necrosis, chronic pancreatitis. I personally avoided bariatric surgery because with the advent of medicines, actually, in the last year or so, there's hardly any endoscopic procedure or surgical procedures being done, dramatically come down, and I'm sure we need not talk about surgery or endoscopy for bariatric disease. And EDGE is a very, very focal segment of the entire GI pathology, so I thought I'll exclude that. There are several caveats in this based all the published evidence, case selection, cost, expertise, additional procedures, and long-term outcomes are all the caveats involved in this. Now, there are some gray areas within endoscopy. When I started my practice, they told me that pneumatic balloon dilatation is better than Heller's myotomy. But when POEM came, they tell me that POEM is better than pneumatic dilatation or Botox procedure. Early GI cancers, variable in different parts, ESD in some parts of the world, EMR in some parts of the world. Obstructive biliary pathology, traditionally it was ERCP. With the incoming endosonologist, which is a separate specialty, there seems to be a tug of war between the endosonologists and the ERCPs as in today. Gastrojejunostomy. When I started my practice, they told me that enteral stents are better than gastrojejunostomy. But now with the advent of luminal opposing metal stents, they tell me LAMS is better than enteral stents. And the next thing that is going to come is the magnets. And if we just wait forward for the next randomized control trial, which tells me that magnets are better than surgical gastrojejunostomy. One constant debate as to whether it's plastic stent or metal stents. I know that most of you are still arguing on this topic as in today. So it's endoscopy. It's not only endoscopy, it's endoscopy versus endoscopy versus endoscopy because there are a lot of other procedures that have come within the endoscopy. I'll show you a couple of examples of these things. What are the areas of controversy within the endoscopy itself? Achalasia cardia, first trial came in which showed that POEM can be done. Yes, but gastroesophageal reflux is more common among patients who have undergone POEM. Now, what happened was, initially when POEM started, endoscopists declined the role of reflux. But when gradually evidence is built up, they started talking about modifying the procedure. Now we have an anterior myotomy versus posterior myotomy, a long myotomy versus short myotomy, a conventional myotomy versus a selective myotomy. And as in today, I'm sure there is no gold standard in the type of myotomy that you perform. And people feel that the reflex is not significant based on the evidence. But if reflex is not that very significant, then why are we doing these procedures? They started documenting this using a flip right now, and it shows that POEM offers greater Urquhart's reduction but carries high risk of reflex esophagitis. And no wonder that people are talking about POEM combined with an endoscopic fundoplication, or we have these procedures which are published which show POEM in combination with laparoscopic fundoplication. So the crux of the rule, the verdict is that POEM continues to evolve. I'm not saying it's not a good procedure. It's a good procedure in select group of patients, but we need more data to show which type of myotomy is ideal for these patients and whether these patients require an anti-reflex procedure. Majority of the patient, we feel that they require anti-reflex procedure. Till we standardize this procedure and we have better outcomes with POEM, Hurler's myotomy continues to rule the roast in achalasia cardia. Gallstones with CBD stones, ERCP is the option in many centers. No wonder it is that, basically because of the number of endoscopists who are practicing ERCP procedures. Unfortunately, surgeons failed, they did not have much experience with laparoscopic CBD exploration. So majority of the centers across the globe seem to be practicing ERCP as an option for CBD stone. But there are publications which continue to come from centers regarding a single, which is not that very complicated and avoids all the complications of an ERCP. And there is a very recent publication which shows that a single stage procedure combining a laparoscopic cholecystectomy along with CBD exploration is far better, is a viable option for healthcare system that prioritize resource efficiency. So I'm not saying that ERCP is not being practiced. It is practiced very widely across the globe, but we cannot deny that this ERCP is available in every part of the world. In centers where they do not have facility for ERCP, I think still laparoscopic CBD exploration continues to have good role, and it is better than two-stage procedure as far as endoscopic anti-reflex procedure. From the time I started my practice almost 4 decades back, I've seen several of these endoscopic procedures which came, which went. Which came, umpteen number of they come with randomized control trials, meta-analysis, then everything goes into oblivion. Right from strata procedure to endocinch procedure, from Muse procedures to anti-reflex mucosectomy, ARMA to ARMS procedure, every single procedure that is coming into the market stays in the market for some time. And then obviously we don't see anything about that procedure subsequently. We see, of late we see some of the publications coming in favor of TIF, but I'm not very sure how long this procedure is going to last. As surgeons are concerned, endoscopic anti-reflex procedures will never be able to overtake conventional laparoscopic fundoplication, basically because of it's an established procedure. And all these procedures which have come on the endoscopic side are either not cost effective or the long-term results are not that very good compared to surgical procedure. And mind you, whenever I'm talking about surgery, I'm talking about laparoscopic surgery, not open surgery, which is associated with wound infections, wound disruptions that we were just talking about. Walled-off necrosis. This is another beautiful thing that has come into market actually. Now, there is no doubt that placement of lumen opposing stent in a walled-off necrosis with that less amount of necrosum, in close approximation to the stomach or duodenum, endoscopy is best. There is no doubt about this. But not all walled-off necrosis are just focally localized to the stomach or to the duodenum and you can just puncture the thing. Now we have umpteen number of these things actually which have come. Actually, now there is no definitive gold standard on the endoscopy side which has to be practiced. I told you with it regarding plastic versus metal stent. And of late, we have three huge uh, divaricated trials that are coming up regarding endoscopic necrosectomy, whether it has to be done at the first go or it has to be done as a step-up procedure. This is divided opinion across the endocrinologists across the world. And there are three randomized controlled trials which have come, which have not, and recently we have this, the Accelerate trial, then subsequently we have the Destin trial, and recently, just actually the other day, they told me that the Wonder One trial is published. Still, we are not very sure whether we are supposed to do necrosectomy at the first stage, or you have to wait for the thing and do the necrosectomy subsequently. US guided gallbladder drainage for inoperable malignant disease. Now, this is compared to percutaneous cholecystostomy, so I'm not going to discuss about this. US drainage for gallbladder disease for benign disease, absolutely. I don't think this is acceptable because this is going to cause a lot of problem for the surgeon who does the procedure. Technically, it is difficult. The overall outcomes may not be that very different from a laparoscopic cholecystectomy, but definitely we have to close the duodenal rent. For that, we need to mobilize, cauterize part of the duodenum to make sure that you close that rent in the duodenum. So it is not going to be as simple, and it cannot certainly be done by a general laparoscopic surgeon who does the routine gallbladders. Malignant gastric outlet obstruction, the new kid in the block is the US guided gastrojejunostomy, which is comparing, and this is not a standardized because it is a fistula, not a gastrojejunostomy. The site of USGJ is variable. Wherever you strike it, The size is less than 2 centimeters. The shape is circular. The size patency is stent dependent because the moment you remove the stent, it closes. Complications are more. Limited number of people can do the procedures. Low publication evidence performed in only select centers. Technology availability is limited and financial implications are quite huge. The stent is very expensive. At least in India, laparoscopic gastrojejunostomy costs peanuts as compared to the surgical EUS lamps placement. The hospital stays similar. Time to chemotherapy is similar, not very different in laparoscopy. You don't have to compare with open surgical gastrojejunostomy as of today. Now, as these endoscopies are competing, actually, as I told you, we've had a debate about enteral stent. Now you have this lumen opposing stent. The next kid in the block is actually 6 months from now. You will see a randomized control trial coming in between the lumen opposing stent and metallic stent, and it is going to be a debate between interventional endoscopists, endocrinologists, and magnetologists, the new kids in the block who are going to come against the surgical gold standard of laparoscopy. And you see this umpteen number of complications. See, it's a blind procedure. You understand, GJ, you go into the jejunum, you insufflate, instill some blue color into the thing, blue solution into the thing, and blindly hit at that loop. Now, this is one such lumen opposing stent which was fired, and it got lodged into the free peritoneal cavity. You can see this considered unfit for surgery, but the same time, because it's migrated, we had to take this patient onto the theater and then did the same. Patient who was considered unfit becomes fit for surgery, and we do a laparoscopic gastrojejunostomy. The stapler is hardly, the price of the stapler is very cheap as compared to the lumen opposing stent as in today, and the procedure time does not take more than 20 to 30 minutes in any surgical center who are doing these procedures routinely, and the recovery time is. And I don't know whether you have seen this beautiful article from Sham. Very beautiful article which says that axiostent, which has come for treating walled-off necrosis, cannot be used for other indications, basically because of umpteen number of complications that we see when we start using it for the other indications. And he very clearly says in this, saying that the stents which have to be designed for the other procedure may have to be slightly different from what we are using as in today. Beautiful article, Sham. I think everybody should see this article. And one stent is not a solution for every possible solution, problem that you have. The other thing that we talk about is subepithelial tumors increasingly being detected. There is no doubt that you have small lesions which are on the luminal side can be extracted endoscopy. Larger lesions require surgery. There is a gray zone which requires both endoscopy and where umpteen number of procedures designed whether depending on it can be predominantly endoscopic procedure or a laparoscopic procedure. This combined procedure like this. Here, I'm taking help of an endoscopy. Actually, we are doing this. Actually, this is a large cyst, which is both endophytic and exophytic. Methylene blue, and then we do. You can see this certainly cannot be done endoscopy. You can see this, we excise neuromuscular. Likewise, a large lesion along the lesser curve here. We have to work with tandemly with endoscopy. At the end of the process, the endoscopist is trying to put this lesion into the endobag here. So this we are working in tandem to improve the overall outcomes. It is not just pure surgery or pure endoscopy. We have to have some collaboration. And again, a case like this, which we thought predominantly exophytic lesion, we thought a sleeve gastrectomy would do the thing. Put the stapler, we realized that we are compromising with the gastric lumen. Blue from the endoscopy. Zero resection. We made a gastric tube, the mucosal tube, and then stapled this procedure. You can see that the gastric lumen continuity is maintained. There is no leak. And then subsequently, we close the seromuscular incision. This integrity of the incision there and the muscular, the mucus. Started borrowing ideas from the endoscopists. Actually, here we have started injecting from the serosal site right now. So under endoscopic guidance, you can see this, we inject this, and then we start where I borrowed the speedboat from the endoscopic colleagues here. You faster inject and cut it. The mucosal tube here, that the lesion here, we can just staple this lesion. You can see that that is the mucosal lesion. We staple this and this. Likewise, we do combined endoscopy. For early gastric cancers, ESD could be an alternative, but it is not suitable for every patient that we see, though we are seeing increasing. This is one such procedure wherein we do combined endoscopy, laparoscopy procedures again, and the lesion is too big, so injected submucosally, then we do a onto the lesion prominent using some material in the does to prevent any the malignant. But you see that actually endoscopy, they're talking about full thickness resection or ESD procedures. Now they want to combine it with laparoscopic lymph nodal clearance. This is sounds very absurd. I think as in today, we have to very clearly decide which patient has to go for surgery, which patient has to go for procedure. Rectal ESD, again, we have a transannal endoscopic microsurgery, which is faster, basically because of the rigid instrument, good energy sources, and there is a lot of data to show that these procedures can compared to what can be done in the procedure. Likewise, large leiomyomas like this, endoscopically using laparoscopy. You can see this. We have a muscle layer here. other procedure. Like, see, this is an attempted endoscopically. You can see this. Again, they keep telling us that this patient is unfit for surgery. Now, this patient underwent an endoscopic third space dissection of this. Unfortunately, could not be resected completely, ended up with a perforation, and this is thoracoscopy. For major endoscopic procedures like this is fit for surgery also. Now you can see this, we take this up. This again, we have to know the limitations of endoscopy. This is another full thickness resection that was attempted endoscopically in a major. This sort of a defect that is created after this sort of a defect that is created following a full thickness resection cannot be closed by any endoscopic suturing devices or the techniques that you have as in today. So you can see this is a big hole. It's not about open surgery right now. It is all about laparoscopic. And then so early third space endoscopy, limitations understood. It is useful in select limited indications, but not for all patients. Chronic pancreatitis, beautifully explained. I'm not saying it is not surgery versus endotherapy, but we have to decide which patient for surgery, which patient for endotherapy. We have a beautiful medical board in our own hospital, and we decide patient with dilated ducts, floating stones in the pancreatic duct can be easily done endoscopically. Single stone in the head region, yes. But majority of these patients who have multiple stones, complicated, non-dilated ducts, these are the patients actually who require definite surgical procedure as in today. So in addition to the 7 alternatives that I talked about, we have an industry which has come into big way, and industry seem to be dictating evidence-based medicine as in today, especially for endoscopy. And I just asked AI as to approximate percentage of industry-supported publications in gastrointestinal endoscopy, and it says 28 to 50% of the publications in GI endoscopy feature industry support. Phenomenal thing, and it is increasing day by day to see that industry is supporting and industry is dictating this. And this obviously is going to change the line of management in this. Likewise, what is the approximate percentage of industry supported publications in GI endoscopy? You can see this actually. There's variable funding disclosure with only 67% of the articles reporting sources and 77% addressing conflict of interest. So industry payments to the gastroenterologists have increased, underscoring their role in research, though exact percentage for gastrointestinal endoscopy alone remain around 28 to 50%, could be broader in some of the trials. So the verdict is most of them are supported by industry, and industry seem to be dictating this, and the practices are changing every day as in today. The other thing that we talk about, carbon emission. This is what we are worried about. Beautiful article published from my own center, which shows the amount of carbon emission that is produced from the endoscopy department because of the umpteen number of disposables that are used. Phenomenal study, and we have a beautiful study on the surgical side which shows that the amount of disposable that are used on the surgical side is far less as compared to endoscopy side, and the contribution to the carbon emission is far less from the surgical side as compared to endoscopy side. So the future is all about AI, which will help resolve majority of the issues of these gray areas, both in diagnosis, predicting response, recurrence, complications. So it is likely that we can decide which patient has to go for surgery, which patient has to go for endoscopy. It is going to predict which endoscopic procedure would be good. And basic understanding of the disease may help us in changing the entire concept of managing disease. Maybe therapy is going to be replaced. AI is going to replace surgeon. Maybe endoscopists in future, and is going to dictate the line of therapy for us. Majority of the GI endoscopy publications are published in low impact journals. Actually, so I do not think they can be considered as gold standard as in today. So traditionally all endoscopic surgeons believe that they can get rid of surgeons for majority of the procedures. This is a beautiful cartoon which came almost about 3 decades back when we first showed the notes procedure. People think that they can get away with surgeons, but this is not the thing. Flexible endoscopy started with surgeons, and many surgeons still continue to practice endoscopy across the globe. And many surgeons in US, Europe continue to practice endoscopy, even advanced endoscopy in many of the centers. So if you ask me, endoscopy versus surgical management in gray areas of gastroenterology, this is not a challenge, context, verdict against surgery, but is a tribute to progress. And it's an evolution or a continuum of gastrointestinal care with patient as the center. So we decide which is best for the patient. And mind you, diseases declare their territory, and every single technique, be it be surgical, endoscopists must respect the territory of the disease and take a decision as to which procedure is apt for the patient. This is what we're going to practice. And finally, I'll say endoscopy definitely scores. There is no doubt about the role of endoscopy in current day clinical practice, but the evidence is limited to low impact journals, and it is not practiced globally across the world. Limited centers practice, especially if you talk about the edge procedure or the ESG procedures, how many centers can practice this? But surgery, which is practiced world over, people with general surgical training should be able to do majority of the procedures that I've shown you here. But whereas endoscopy or EUS or third space endoscopy is done by limited number of endoscopists across the globe. And mind you again, when anybody is comparing endoscopy with surgery, as in today, it is endoscopy with laparoscopic surgery or robotic surgery, but not with open surgery as in today. Thank you so much once again for the patient here.
Well, that was phenomenal. Thank you, Dr. Juviral. I love your last slide, by the way. Even as an endoscopist, I can appreciate that slide. So thank you very much for that comprehensive review of surgery. We're going to move into our panel discussion. And before I do that, I just wanted to confirm Dr. Kaul maybe have called into a procedure, but I have a number of questions for the panel that I wanted to get started with. Dr. Chandrasekhar, is that okay to move directly into the questions? Okay.
Yeah, I think we will start what we have decided. We will, first question is from your side, to both the speakers, and expert comment from your side. And after that, we have other panelists. Then we'll go for the second round of discussion about comment and other thing. And before you start, I just want to compliment both the speakers. I know Dr. G.V. Rao is a fantastic speaker. And the last slide, even an endoscopy, I like that surgery and the rows and the endoscopy score. But we are discussing about scoring only now. Okay, now I like that your fitness about what is the once it was unfit, it becomes a fit later on. I think I appreciate that. I think there should be an objective way of assessing the fitness for surgery before declaring just for our satisfaction. We should not take it for endoscopy. And I also agree with you that the US for the gallbladder benign disease should not be taken, and it's a malignant. Okay, and all this technology not available everywhere. And the point now it is going to be available in future also. It is going to take up. Now, what was UGA bleed at one time, a surgeon domain had become endoscopist domain. So the pendulum is keep swinging. And I like that your slide, endoscopy is equivalent, endoscopy. That means it the same slide, another one slide you said, this is the attribute to progress. So endoscopy is not static, as surgical domain also progressing, endoscopy also progressing very well. And I appreciated your slide videos of Lex actual laparoscopic endoscopy cooperate. I think that is going to be the future. With this, I welcome both the moderators and the panelists to start the proceeding. We'll ask the question or expert comment from, we'll start from Dr. David Huss.
Thank you so
Yes.
much. Just reiterating how excellent both lectures were. My first question is really for both Dr. Rao and for Vivek. In the United States, what we find is that there isn't as much robust training per se for some of these techniques. And I'm talking about both on the surgical side and the endoscopic side. So there's certainly advanced endoscopy fellowships now, and people are learning all kinds of different techniques. But it's not as if it's always translated into the mainstream hospitals outside of the larger academic centers. And similarly, what I'm seeing is that many of the general surgeons that are trained, they're trained in laparoscopic techniques, but they're not as comfortable, at least in the United States, with open techniques. So they're not comfortable with laparoscopic common bile duct exploration. They're not comfortable if they have a very complicated laparoscopic cholecystectomy, converting that all the time to an open cholecystectomy. And these are younger surgeons that have been trained in the era of laparoscopy. So I'm just curious, first to hear from Dr. G.V. Rao about if that's your experience in India, or if you've heard anything like that just from the general surgery technique. I do ERCPs, frequently get called to do an ERCP for a bile leak in someone that has done an incomplete cholecystectomy because they have not been able to get out the gallbladder because it's massively inflamed, and they left an open bed, and therefore they need a stent in order to actually minimize the bile leak.
Yeah, absolutely. I fully will agree with you about the training in laparoscopy. With the advent of laparoscopy and robotic surgical procedures, the use of open surgery has become less and less, especially in some of the common surgical procedures that we do. But what you said is absolutely true. Some of the younger surgeons who are getting trained in laparoscopy are not that very comfortable with open procedure. But the biggest thing that has happened was actually there is a lot of difference between laparoscopy and robotic surgery. People who are not comfortable with laparoscopy are the people who are practicing robotic surgery. And I feel robotic surgery, especially if we choose properly, I think we can get away with not opening in majority of these patients because robotic movements are more as compared to the laparoscopic movement that we have. So especially in some complicated cases, actually, we feel that surgeons are also shifting from laparoscopy to robotic procedures. But it's not that it is done in every patient. But I think what you said is absolutely right. I think people should have some exposure to open surgery because you always cannot have a surgical standby for an open surgery. But I think in majority of the centers which are doing advanced surgical procedures is not done individually, they do as a teamwork. So there's somebody else who's taking up this open procedure.
And Dr. Vivek Sandeep, do you agree that while the techniques are there and they're really becoming advanced and really impressive, do you think there's ample number of people being trained right now to really expose the general population to some of these endoscopic techniques that could theoretically be better than some of the surgical techniques?
I think that's a very important point that you bring up. I think when it comes to just ERCP or diagnostic EUS, we have very structured training historically. We have good standard numbers for how many ERCPs or EUS, what type of ERCPs someone should do before we graduate. But when we extend it a little further and it comes to interventional EUS or third space endoscopy, I don't think there is actually structured published. It's more of expert opinions. And most people in practice, at least what I see is, they go to these courses, they go to these industry sponsored or, expert centers that do courses, and then they have to get started somewhere. So there definitely needs to be a more focus on proctorship, structured training, attention to safety events and adverse events before we get these procedures done. And it's ideally started in places in university hospitals where you have good surgical backup, which is why I think it's a very important point. Even when Dr. Rao was showing those videos, you do a full thickness resection or you try to do a gastrojejunostomy, it's easy until it's easy, and it can go wrong real fast. And when it goes wrong, who's there for our backup? It has to be an expert surgeon. And the same point that you brought up, cholecystectomy seems to be much more straightforward than bile duct exploration, but we do see a lot of bile leaks. In fact, a lot of our ERCPs consultations are for bile leaks. There is actually data that's published from the late 90s, when laparoscopic common bile duct exploration used to be performed in 40% of cases, but by 2013, it was just 8%. And there are training programs where surgery residents graduate with just one laparoscopic bile duct exploration, and this is all published data. So we are losing some skills, and that's basically due to progress in certain ways. I think with laparoscopy and robotic techniques, we're losing some skills. And my fear is also the same with AI in the future, where we're heavily reliant or dependent on AI for some of these things, and we may subconsciously be losing some of our endoscopic or surgical skills.
So just as a follow-up, and then I see Dr. Vivek Kaul is on, and I'll defer to him for the next question. Are we confusing the outcomes that you've reported because it's been done at, let's say, advanced endoscopic centers with what real-world experience is? Can we trust that if someone tells us that they do notes or that they do poem, that because there's really no guideline, at least to my knowledge, in terms of the training, that they really have the training that is outside of those advanced centers to be confident that those techniques that you've shown are better than surgical techniques should be implemented? Or should we only do it at endoscopy centers that have, the volume?
I think you're right. It has to be, when Dr. Rao presented that slide saying only 1% of endoscopists actually do this, and the remaining 9% are propagators and 90% of them practice. It's just not feasible for everyone to get started with these procedures just because we have very good ROSI data, right? Because you need to have the appropriate setup, expertise, and backup before you do these procedures. My personal opinion is I would never advise anyone to do an EDGE or EUS gastrojejunostomy in a community hospital or where you don't have adequate surgical backup. But that's how the field also progresses. It has to start somewhere, which is why I finished my presentation saying if we're having this debate 5 to 10 years from now, it's going to look a lot different from what it is now. And the comparison is always surgery, right? It's a gold standard. It's established, which is why all the RCTs are designed and compared with how good or how close can we get to surgery. There has to be a start somewhere. So at this moment of time, yes, it's only expert centers and experts who should be practicing a lot of these. But 5, 10 years from now, I think the landscape will slowly change.
I think we'll move on to Dr. Vivek.
Hi.
I just want a short, brief answers to the questions so that we'll take up more questions. Okay. Dr. Vivek,
yeah, no, that's
questions
great.
and your comments to both
Thank
the
you very
speakers.
much.
Okay.
Yes, thank you. Excellent presentations by both Dr. Vivek Sandeep and Dr. G.V. Rao, of course. And Vivek, I applaud your courage to go against the legendary G.V. Rao, but I think you stood your ground. And of course, amazing insights from both parts. And I should also say, in a debate format, it's important to not only be objective, of course, to refer to the data at hand, but also in a fair and balanced way acknowledge both sides, right? And you both did that very nicely, and that is to your credit. I also want to take the opportunity to introduce our panelists, Dr. Baiju, who's a surgical gastroenterologist, Dr. Prasad, who's also an eminent surgeon, works in Chennai with Dr. TSC, I believe, and Dr. Bhavanta Gamaje and Dr. Sanadapan also on here. And I think hopefully they will also get a chance to ask some questions. To me, the takeaways, and everything is a learning opportunity. I first a comment real quick, is that I think collaborative practice is the message I'm getting, right? So the teams that do the best job with their patients, who are patient-centric, and they have multidisciplinary approach to the same problem solving, they come out usually ahead of all others. This one-off, I can do this procedure, I can put this device, I can look what I did, that usually does not carry the day. It usually has a negative outcome, and it sends a wrong message to our colleagues and to the juniors. The second point I took away is that just because you have a procedure, you should not do it. And I think the main thing that we have to rely on is what is the appropriate algorithmic position of an intervention in a patient's care. And I think for complex medical surgical problems, that algorithm has to be positioned based on data, based on experience and outcomes. So, Dr. Rao, in your opinion, with the AIG as the leading model, what is your advice? How should teams go about it? Because the best outcomes are with the surgeon and an endoscopic specialist. Give us some advice to the people online. What are the basic principles of how should one go about, let's say, for example, setting up a POEM program or setting up a complex interventional EOS program? What are the guiding principles for that?
Absolutely. I think day one, actually, the best part of the thing that I learned from my institute was actually whenever we have these publications that are coming in, we discuss this one. And then it is not that we are against implementing that in practice, but we take the evidence into account and see the feasibility of doing in a stepwise manner. And credit goes to Dr. Reddy, who makes sure that all these complex or gray zone cases are discussed in a medical board, which happens every day in the institution actually. And then we decide as to which patient has to go for endoscopy and which patient has to go for surgery. At the same time, it is not that we are dissuading the endoscopists to do the procedures. We encourage the endoscopists to do some of the procedures in the theater. We stand by. Not all procedures can be done in the endoscopy suite. So we have to have a very strong collaboration between the endoscopists and surgeons. And the endoscopists also pick up technical tips from the surgeons. Just by doing endoscopy procedures, nobody will attain the technical skills. You have to see the surgical procedures also. So actually, I see my own medical gastro colleagues who keep coming to the surgical theater, keep watching surgical procedures. And whenever they have a complication, actually, it is not just refer it to us, actually. You understand? They just come and stand by to see what went wrong and how it can be corrected again. So it is introduced in a stepwise manner. And some of these procedures that we landed in complications, we know that these procedures are going to have some complications. So we tell them beforehand that a combined endoscopy, laparoscopy procedure or a surgical salvage procedure can be required. So it's a stepwise manner, and we have to counsel the patients continuously, tell them adequately what is the evidence available, what can be practiced. I think that way we take the patient into confidence. I think we should be able to do this advanced endoscopy procedures. Otherwise, it's very, very difficult to carry forward.
I think
That sounds like
I
a good
strongly
approach.
endorse
Yes.
please. I strongly
Go
endorse
ahead.
the view of Dr. G.V. Rao, and the physician should really go to the theater and watch the procedure, particularly if they are complicated. The anatomy, what the endoscopy anatomy looks different from when you do the laparoscopy or
Yeah, actually,
complication.
Vivek, I keep telling when I started discussing about endoscopic gastrojejunostomy, I asked my endoscopy colleagues, do you know what structures the needle goes through? Nobody knows. All they see is a dilated loop there and they just strike it. I said there is a transverse mesocolon there, or it could be a greater momentum there, which is in between. See, we should know. So when you see the laparoscopic side, you'll know the thing actually. You understand? And it is not always actually like a surgical GJ where it is done in a particular point. It is wherever it is getting approximate, you just shoot it and then release the stent. So basically, that has got some limitations actually. So even the GJ, endoscopic GJ practice has to be refined. It is not just you find a loop and strike it. You have to make sure that you're striking it in a good dependent area so that you get good results.
Dr.
Absolutely.
Yes.
Go ahead, Doctor, please.
Dr. Prasad, you have a question and comment too?
Yes, I was going to
Unmute
ask the
yourself.
panelists. Yeah.
Good evening, panelists and all the speakers. It was a great presentation by Dr. Vivek. You really did a great job defining what exactly is the gray area, how a surgery or endoscopic way you can deal that problem, and it was very balanced. Wherever there was a area where there no surgery scores, you graciously accepted the role of surgery. At the same time, you presented your point where endoscopy has got a role. And in that aspect, your presentation was very balanced and finally concluded that the pendulum is swinging this side to that side, but most likely in the future it's going to swing towards the endoscopy. I wish you good luck. And Rao, as usual, I mean, he never fails to surprise the audience. He is a hit movie director in respect of story, I mean the content, the presentation, the colors, the novelty, in every aspect. And all these things are backed by proper data. And he has argued so well. And I consider he is the spokesman for surgical division in India. No, very few surgeons can argue surgical cases so well to prove that surgery scores over everything else. I do agree. The final triumph of surgery is providing solution to the patient. That is what makes us stand apart from other people. Well, Dr. Rao, I have some questions to you. See, endoscopic full thickness resection, of course, you have clarified in your presentation. In case of EFTR for GIST, it is gaining a lot of traction nowadays. As a surgeon, what are your specific concerns regarding intraperitoneal seeding during these procedures compared to the controlled environment of a laparoscopic wedge resection?
Absolutely. Suppose if the lesion is ulcerated on the endoscopic side, if the mucosa is breached, you should never do a full endoscopic full thickness resection.
Very good.
If the mucosa is intact on the luminal side, yes, and the size is small, you can do an endoscopic full thickness resection. But a lesion that is ulcerated, where the mucosa is breached on the luminal side, should never ever be done endoscopically because it is already ulcerated and you're likely to spill the cells into the peritoneal cavity.
Okay, right. I think we will come back to again, Dr. Prasad. Dr. Beju is a surgical gastroenterologist. You have a comment and a question to the speakers, then we'll move on to the second round to Professor David after you. Dr. Beju.
Thank you, Dr. TSC, for giving this opportunity. And both the speakers were doing well and they are arguing for their stakes. And I think I agree with Dr. G.V. Rao regarding the this thing. But G.V. Rao works in a place where both medical gastroenterologists and surgical gastroenterologists are almost equal level of supremacy. But I am a person who is doing both endoscopy procedures and laparoscopy procedures. In my place, probably I may be dominating over the medical gastroenterologists because I do more of endoscopic and laparoscopy procedures. But some places, the endoscopist will be dominating, and the surgical gastroenterologist or surgery person may not be that much dominating. So it depends on the place where you work that the endoscopy is taking over or the surgery is taking over. I think the place does matter, is it not?
Absolutely right, Baiju. Actually, there is no doubt about this. It all depends on the place where you're practicing. There are a lot of factors that are involved. We have a very good therapeutic endoscopist. Obviously, most of the cases could be done by them. But again, it's variable. That's the reason why I'm dead against these guidelines. Because see, what happens is, wherever an RCT is published, it is published in a center where they have good expertise on both the sides. But the same thing may not hold good in every single center across the globe. So it could be some center where they have better laparoscopic surgeon, and in one center it could be a better endoscopic surgeon. So these guidelines or RCTs tell us what are the emerging specialties, techniques, technology. But at the same time, I think the procedure has to be dictated by the patient and the expertise available in the local center.
And also, I have visited some of the centers in Shanghai where the surgeons do the endoscopy. So only the surgeons do the endoscopy. And probably they'll be having a better outcome than the medical gastroenterology. Is it not that?
I mean, actually, this again, Baiju, actually, surgeons who are doing both continue to do endoscopy in addition to surgical practice may be good endoscopists. But surgeons who have totally stopped surgical practice and switched completely into endoscopic practice, you understand actually there could be variation. Please try to understand. You could see basically if you're doing both the procedures, then obviously your skills will improve every day when you're doing the endoscopy procedures. But if you're not doing any surgical procedure, be it laparoscopic procedure or robotic procedure, and you continue to do only endoscopy procedures, again, there is a limitation to what level you can improve your endoscopy skills. I mean, that's my opinion. I mean,
absolutely.
Okay, Professor David has your
Yeah,
now second.
Yep. Thank you. I wanted to talk about something that's sort of become so mainstream that it really important to talk about, and that's the GLP-1 antagonists, or agonists rather. We're seeing that constantly in patients that probably don't even need it. But I'm curious, Dr. Vivek Sandeep, where do you see endoscopic sort of sleeve gastrectomy in comparison to the medications? Is it a bridge therapy? Would you still recommend that, or would you recommend patients have theoretically medications first prior to more definitive surgery?
I think that's a field we're still trying to understand more. Basically, with the advent of these medications, I would say both bariatric surgeries and even endobariatrics has taken a hit, because obviously people can get something really non-invasive, either injections or now even oral medications. But in terms of the combination therapies, we're just seeing emerging data, and we're seeing more synergistic weight loss when they're combined with both endoscopy or surgery. Right now, I would say sleeve gastroplasty endoscopy is more of a bridge. It can be definitive in a lot of patients, and it really depends on what the patient wants. Some patients want absolute weight loss, some patients want comorbidity improvements. And I think that's where this field will change more in the future. And there will be a role for each of these procedures, but it's not going to be the same as what it used to be with bariatric surgeries. I mean, to begin with, bariatric surgeries were not for everyone, right? Only, if you look at the data, only 1 to 2% of the people can actually get a bariatric surgery. Now, the remaining 98%, when we open up these options, this will be more patient-tailored approach where patients are able to pick and choose what they want based on the outcomes that they need to achieve.
Surprisingly, actually, my surgical colleagues will agree with me. When ESG started, at least in India, when ESG started, people started practicing, the laparoscopic surgical procedures declined. The industry told us that the number of staplers that are being sold for bariatric surgeries dramatically declined. With the advent of drugs that are coming to the market, the number of ESG sutures that are sold is almost zero right now. You understand? Actually, there hardly anybody who's doing an ESG procedure in our country, because everybody wants to go for the medical line of management as in today. So bariatric surgery is one thing, but be it laparoscopic or endoscopic, I don't think it has got any future, basically.
Yeah, and you have a lot.
With the duodenal DMR comes much more, maybe that is much more simpler than the, So duodenal mucosal resurfacing comes, if it really makes a great impact clinically and it is doable, then that will maybe a balance will strike between the medications and DMR. So
No,
I think I agree with you.
There's definitely a role still in the future, in my opinion, because these are very expensive medications, at least in the United States. I think in India it's cheaper, and it's a lifelong commitment to these medications. Not everyone will be compliant. So right now, I think the pendulum is swinging way in favor of these medications, but in the future, I feel like it's going to swing back a little bit.
Vivek, the thing is actually there is a strong thing about the weight regain that you see both following laparoscopic surgery and endobariatric surgery. So, I mean, it is, I think, I'm not very, I probably think the drugs are going to become cheaper and more drugs. I mean, I think the gastroenterology, endocrinology should tell us actually, I think that is going to take away most of the bariatric practice.
I agree.
Yeah. One more, Professor Vivek Kaul is there, or Dr. David, you have one more question?
Sure.
Dr.
Vivek is there. Dr. Vivek,
yeah, I'm here. I'm listening. I think one of the big things was pointed out earlier was the fact that surgery, especially general and laparoscopic surgery, now has been around for 30, 40 years and has stood the test of time. The techniques have been refined and standardized across the world, right? Even in low resource environments, certainly in the first world, but even in the second and third world, the average performance of these is pretty good, right? So it's going to take a long time for endoscopic surgery to reach that level of proficiency and large volume outcomes, right? So I think that that's one point that needs to be considered. How do you think, Vivek and then GV Rao, how can we achieve that ultimate goal? Or do you think should it be reserved to the ivory towers, where only a focus is on complex endoscopy and establish a system that not everybody needs to be proficient in these, and that centers be established, like we have learned from some of the European countries, where care is concentrated in a particular area. Which are the two paradigms you see happening? Quick responses from both of you, and then David might have some additional questions.
I think we'll know the answer only if we do more of these studies and trials, right? We always start with comparison with the gold standard. It's more like father, son, or big brother's younger brother. We have to start with non-inferiority trials and see where we go. And of course, if we're not able to match the surgical standards, at some point we have to call it quits and move on. So we may not be able to offer for everything, but certainly, especially with achalasia, I feel like, we've made huge progress. So we have to figure out which of these conditions would endoscopy be as close to surgery as possible. So time will be
and also with funding from non-partisan sources. I think that was an important point made. Nothing to take away from the quality and diligence of the investigators, but I think does cast a shadow when you have a reported conflict. Dr. Rao?
Vivek, I think you should very well realize this. Actually, some of the randomized control trials which are coming from very high volume centers, surgeons are open to this technology and technique. That is the reason why they're participating in these randomized control trials.
Right.
It is not that the surgeons are not open to these procedures. So in high volume centers where procedures are being done, if the RCT is being done, it means they weigh the pros and cons of doing the procedure. So everybody is open to revolution or evolution in medical practice. If something is better, then obviously from the interest of the patient, we have to accept that. So I think as what happens in surgical field, advanced surgical procedures are not done in every possible center. You understand? Routine general surgery is done as an outpatient procedure, whereas advanced surgical procedures are done in only select centers. Likewise, advanced endoscopy procedures can be practiced in select centers, and maybe difficult cases can be referred to those centers. And the routine endoscopy practice can be done everywhere. I mean, that's my take on the thing, actually. But it is not that, see, in a center, if I go to a peripheral hospital, they will not be able to do a laparoscopic Whipple that we do routinely in my center. And we don't expect them to do it, actually. You understand? But at the same time, somebody is seeing some procedure on the workshop on the screen and you want to duplicate that on the procedure. That is not what is acceptable in current day.
And I think that's a very important point. The reason I brought this question is because I think in the initial enthusiasm of where we are today, I think there is some sense of more dissemination of use where it probably does not belong. And I think we have to be careful about that. David, please go ahead and take over.
Okay, Professor David, David has.
Yep.
You have a question and last comment before we go for the chit chat. We have one more round quickly. So,
yes. I was just curious regarding, we didn't really talk much about colonic issues. And a lot of times for those of us that do large EMRs and things of that nature, for large non-pedunculated colorectal polyps, surgeons are often called, of course, when endoscopists can't resect everything or if there's a perforation. Is there any complication or sort of compromise of surgical resection if there's repeated attempts, if someone's going to do a robotic resection or a laparoscopic resection, Dr. G.V. Rao?
Yeah, I mean, see, it is not that we do the surgical procedure. We do take help of endoscopic assistant. At the end of a resection anastomosis, I make sure that the integrity of the anastomosis is good by an endoscopy. If I do a low anterior resection, I do an on-table endoscopy to make sure that the anastomosis is intact and there is no bleeding at the staple line. That's the basic thing that I do in my practice. Otherwise, I ship the patient into the ward and the patient is bleed. Actually, So basically, say these are all complementary procedures. So actually, that's the reason why I think there is a strong this thing in, at least in India, to teach surgeons basic endoscopy. I'm not asking about advanced US procedures or complicated third space procedures, but basic endoscopy, how to put in a clip, how to diagnose, see a bleed. So these are the things I think basically everybody should know. So basically, we do complement each other.
So there's no risk of any submucosal fibrosis or anything that makes your job tougher.
Absolutely. But see, on surgical side, whenever we have this resection, we have ample amount of bowel to resect on either side, actually. So we don't resect right onto the site of the thing. But you understand? But suppose if you have to do a POEM procedure, I mean, a HLS procedure after a POEM procedure, you understand? Yes, there could be some limitations. Yes, because of this scarring that is induced during the procedure.
Okay. Last minute, do you have any comment or question, Dr. Prasad? Unmute yourself. Please unmute. One last question. Grish, you have a question?
Yes, sir.
Grish?
My question is regarding this walled up necrosis, pancreatitis, and whenever they are very serious and they are within 4 weeks, wall is not formed, then we are in soup. In which way we are going to deal with? And abdominal compartment syndrome is going on, wall is not matured, neither, and there is a lot of necrosis. So in which way we are going to tackle this? Because neither we can do endoscopy, US guided drainage, and nor we can refer them for surgical exploration. In which way we are surgical drainage bad? So in which way we are going to treat that? Lot of cases we are getting nowadays also.
Okay.
So
if the abdominal compartment syndrome is not there, then the interventional radiology is the one preferred method. That is the standard of care. I think what Dr. G.V. Rao is going to tell. Let's see. And Vivek, your answer?
No, I agree. I think less than 3-4 weeks, endoscopy has limited role. But if there's no abdominal compartment syndrome, bowel ischemia, perforation, surgery has limited role. I think interventional radiology is the bridge.
Okay. Thank you.
Okay, now the time has come for the last 7-8 minutes for a chit-chat session.
One clarification regarding this.
Yes, G.V.
Whenever somebody is talking about laparoscopy versus endoscopy versus walled-off necrosis, every time the endoscopy keeps saying that there is increased incidence of pancreaticocutaneous fistula. See, please, actually, whenever we're doing a walled-off necrosis, which is in approximation to the stomach, it is as good as putting in a stent. We're doing a gastroenterology. There is no way that you can have a pancreaticocutaneous fistula. These fistulas occur only in those patients where they have extensive necrosis outside, and then we start draining them outside. You understand? But standard thing what the endoscopist put in a stent, the same laparoscopic cystogastrostomy that we do, I mean, there is no way that you can have the pancreaticocutaneous fistula. But everybody keeps quoting that literature, saying that high incidence of this, that's the reason you have to do endoscopy. Please try to understand that these happen only when you're doing complicated walled-off necrosis, which have gone beyond the stomach and duodenum.
Okay, so the fistula doesn't occur just because you do laparoscopy. That's what we mean. Okay, now well, I think wonderful speakers. Both the speakers did a fantastic job. G.V., I liked your first slide, which really reflects your kind of the passionate endoscopist and obsessive surgeon. I really liked it. And Vivek, you did a fantastic job balancing yourself and taking endoscopy where it is got a edge over the surgery. At the same time, how do you respect the surgical technique also? Now come to the last part of it. Professor David will start from this. Professionally, if you want to change one decision in your life, which will do that?
I think if I could go back and tell my mid-50-year-old self something when I was in my 20s, I would tell myself to focus on things that I really enjoyed doing professionally, as opposed to things that I felt that I was obligated to do professionally. I think I spent a lot of time doing things that I thought I was required to do to advance my career, as opposed to sometimes things that I really enjoyed. And it took me a little bit of time to realize that when I was doing things that I really enjoyed, it snowballed and had an effect that made me that much more successful. So I would tell people to focus on the things that they're passionate about, and find that if they really do focus on that, you're not really working, you're just doing what you're passionate about. And it never feels like going to work. It just feels like you're following what it is that you're excited about.
What is the turning point in your professional career?
My professional career? I would say when I started to have children. When I started to have children, I have 3 children, and I recognized that I wanted to be just as good of a father and husband as I was as a physician, or what I was aspiring to be as a physician. But it required a lot of job crafting and a lot of balancing. And so that's when I started to thoughtfully say no to things that I really didn't enjoy, and focused my energies professionally on things that I was very passionate about.
Who has been your mentor?
I've had several, and I've been very, very fortunate.
You can name 2.
Name 2? Oh, I don't want to offend anybody. I would say, if I could name 3 professional mentors that I've had, the first would be Larry Brandt, who was my chair of gastroenterology at Montefiore Medical Center, who taught me the importance of detail and the importance of excellence, and the importance of never compromising with whatever I was doing. Secondly would be David Greenwald, who all of these are still close friends. He was my program director, certainly taught me to have fun and be passionate. And then in medical school, I met a young colleague at the time who's not so young anymore, but Mark Pachapin, who's a dear friend of mine. And he really taught me how to make anything exciting. Diarrhea, burping, anything.
Thank you. What's your unfulfilled dream in profession, which you would like to really?
Well, the one thing I have another hat that I wear, which is I do a lot of leadership training, at least locally, for young doctors. And what I'd love to see, because I do a lot of legislative advocacy work, is I'd love to see in medical school curriculums, I'd love to see there be a portion of the curriculum dedicated to helping young doctors start out their training, postgraduate and otherwise, being confident.
I liked it.
Yeah, being confident in the ability to advocate and negotiate with pharmaceutical representatives, legislators.
I never heard of this, anybody telling this. Very good. Yeah. And now come to G.V. Rao. And what is the non-medical book you have read recently? I know you are a busy person, but non-medical book you read and recommend to my delegates, our delegates.
Actually, I like reading science fiction movies, actually. Science fiction, I like reading science fiction novels. Actually, I make it a point to make sure that I strongly believe that they're the ones which people are looking at and then translating them into clinical practice. So I'm fascinated about those things. So I read about this science fiction novels.
I think you created the trend that reading scientific fiction and creating slides, and what really scientific fiction yesterday revealed and today is becoming true also. That is very good. And who has been mentored?
Actually, 2 people. Actually, I told you. Actually, surgical side, I think Professor Angabasham, and endoscopy. Actually, thankful Dr. Reddy, who is mentored.
So I would have easily guessed it. So, okay, what is your unfulfilled dream or the ambition?
A very good question, actually. I really want to understand basic science now. I'm trying to spend some time with the basic scientists right now. Almost 10% of my time I try to see how I can understand that language, which is totally different. And I started at meeting, started talking in basic science meeting, because not that very easy to talk in basic science with the basic scientists. But I think that is one thing that we tend to understand the disease better. And we have, they give good solutions to some of the simple problems that we have. So I really enjoy having a dialogue with the basic scientists.
Okay, we'll come back to you again. Vivek, who is your hero?
I mean, the easy, safe answer is, you, obviously. I've grown up watching you. So certainly from a personal background and standpoint, I think that's the best answer for me. From a professional standpoint, after I've come to the United States, I've had a lot of mentors, But Dr. Pratik Sharma certainly has been a great mentor for me, guiding through fellowship and life afterwards. Dr. Noria Fukami has also been another great mentor for me. So I've had a lot of mentors along the way.
And what is your ambition?
Unfulfilled ambition? I mean, my profession is just career.
No,
is
not
just
unfulfilled. You're too young to say that unfulfilled or not. What is your ambition?
Ambition is, I think, the hardest thing which most of us young faculty coming into practice face is finding a niche. I think the field is changing so much that you cannot do everything. You have to find a focused area of your attention and try to get expertise. I think that's my ambition, trying to figure that out and do something you enjoy long run, like Dr. Haas mentioned, make it your passion.
What was the most difficult thing when you moved from India to USA?
Many things, the culture is completely different. Getting used to the healthcare system, it's very different in India here. So it certainly was a very challenging initial, I would say, year or two. But that probably the cultural shock was probably the biggest factor.
How much you will be able to survive if you come back to India?
You put me on the spot there. It's not an easy answer, and for the same reasons, right? Like the way of practice is different, but if you have a good backup and support system, it's definitely something doable.
Doable. So it is doable. Okay. Vivek call. What is one decision you would like to change, if at all, so for your betterment of your profession?
For me or for the profession?
No, for you only.
For me, professionally speaking, what decision would I like to change? I actually do not have any regrets, to be honest with you. I think, I'll give a slightly longer answer. I think I hope that there are some foreign medical graduates from the US represented here. I think,
Vivek, I request you a very short answer. The reason is we have only
no decisions to be changed. No decisions to be changed.
Oh, no decisions.
No decision to be changed.
Dr. Prasad, you have wide interest in various fields other than medicine. What is your message to the delegates? How a doctor should be apart from the profession? What all you should concentrate?
Well, it's a difficult question to answer in one sentence. As usual,
I will allow you 2 sentences.
Professional competence to the highest level and learning from others. And most important is compassion and empathy.
Okay, compassion and empathy. Now, last round is, who is your, Professor David, who is your sports star and movie star? Star from sports and star from the movie, cinema. Are you able to hear? No, you have to unmute yourself. Okay, while I'm coming, while he's going to answer the GV, who is your the sports star and the movie star?
Sports star, obviously, MS Dhoni is my favorite. Quite calm, composed. Movie star, Amitabh Bachchan is my favorite, all-time favorite.
Oh, it's very easy. It can be easily guessed. Vivek, who is your movie and sports star?
Sports star, if I had to pick one, I would say Roger Federer. Movie star.
I know that will. Movie star is?
Movie star in Hollywood, it's Tom Cruise. In India, I would say it's Kamal Hassan.
Again, I could easily guess it. Vivek, who is your sports star and movie star?
For sports, I think there's nothing bigger than Muhammad Ali for me. And that's a separate offline
you're a boxer,
huh? I am not a boxer, but Ali was more than a boxer. And then for movies, I think obviously for the Indian context, it's Amitabh, and from the Western context, Jack Nicholson.
Okay. Finally, Dr. Devi, your movie star and sports star?
Well, I'm also a big tennis enthusiast, so I would say either Federer, old school, or Carlos Alcaraz currently. Movie star, I do like that call of Jack Nicholson. He's always been amazing in every film I've seen.
Very good. I think I am very happy that to end a note here that we had a fantastic meeting on gray areas in gastroenterology, endoscopy versus laparoscopy. And we have a very young person to represent the younger field endoscopy and a senior surgeon to represent already established world. This is establishing versus established, young versus old, and endoscopy versus surgery. The take-home message is which is superior is not a matter. Who is the one to receive it? The patient, what type of therapy he needs to be, and it should be tailor-made. And the patient should be the winner, not the procedure be the thing. And every gray area, when you have a doubt where endoscopy can score over surgery or surgery can score over endoscopy, we should have a. I always like that pre-cath meeting and the cath meeting and all, no, before cardiac surgery. Like that, every procedure should be, we should have a board of people there where we can discuss which is the best for the patient. With this, I once again thank you, my panelists and the speakers, moderators, delegates who have logged in from all over the world for this fantastic program. I look forward to seeing you in April with the 5th webinar series. There we are going to change from Thursday to Wednesday for some reason. So we have already lined up 7 webinars from April to October. Thank you very much. I once again thank you very much for.
Bye-bye. Thank you.
Namaste.